platelets were normal, all the electrolytes were normal, and other relevant tests, including the blood-borne viral screening, was negative with a HbA1c of 7.1. Now, CSF analysis was done, and it showed CSF pus cells of 8,800 with predominantly 80% and lymphocytes of 90%, 19% and RBC of 5. And there was few intracellular bacilli seen inside the neutrophils. And with regard to concomitant GRBS, CSF glucose were low and proteins were high. And the CSF culture initially grew the E. coli, and the subsequent report showed a CRO E. coli. Other routine tests for the pneumococcal, since he had a heavy pus cells in the CSF, pneumococcal antigen detection, Haemophilus influenzae, meningitis antigen, all were tested and came negative. Blood culture grew no growth. Only the CSF with the CRO E. coli. The MRI was done. It showed no features of, since he had a seizure also, there were features of vasculitis, which was secondary to a probable ongoing infective etiology. Otherwise, there were no other features suggesting of a CSF leak or anything. Now, coming to the history examination and lab evaluation, acute meningoencephalitis, which was CRO E. coli positive, with the risk factors of diabetes mellitus and a past history of a head trauma with previous CNS infection and a recent diagnosis of inflammatory bowel disease was started on immunosuppression recently. Now, the interesting question was that the normal community-acquired meningitis, the organisms were all ruled out, and this E. coli, CRO E. coli was positive for this patient. So what was the source, or where did the E. coli, CRO E. coli come from? So the risk factors were assessed for this patient. And usually the E. coli meningitis are predominantly seen in infants' age and in case of immunocompromised and any neurosurgical procedure that was done. And one positive history that he had was a trauma history with a hematoma, which was conservatively managed, and no CSF leak was historically he didn't say. And we were then coming to the rarer causes. Now, during the evaluation, he had a change in the status of the patient. In which the patient's sensorium worsened on the day 3 of admission. The GCS score dropped to 7, and he was initially started on ceftriaxone, vancomycin with dexamethasone, and which was high based on the organism that grew on the CSF to meropenem and polymyxin. And since the day 3, he had a worsening hypotension and a hypoxia. He was intubated and he was shifted to ICU. Now, the current ongoing diagnosis of the meningoencephalitis with the worsening hypotension and ongoing sepsis or a possibility of hospital-acquired pneumonia was considered. And in comparison to the chest X-ray that was taken on the day of admission, the subsequent X-ray showed a right middle stone opacities, which was obscuring the right heart border. And in the left side, fluffy opacities were seen in the left middle lobe also. Now, the ET aspirate was sent for the cultures, and it showed a strongyloides lava. Now, the working diagnosis, which was changed to acute meningoencephalitis with E. coli with strongyloides hyperinfection. Now, talking about the strongyloides stercoralis, it's a human pathogenic nematode which is seen, and it can cause a chronic intestinal infestation and hyperinfection in immunocompromised conditions. And the life cycle of the worm is
sorry, in the interest of the time, if you can just focus on the relevance to this patient presentation and the learning points, please.
So he was recently started on outside with steroids, which could have worsened the worm infestation, can lead to the hyperinfectivity, and it can cause a translocation of the gut, the CRO, the bacteria into the meninges also, since it's a hyperinfestation syndrome. And also in the describing about the hyperinfection condition, it can involve the lung, GI, and CNS also, with presentation of shock and DIC. Mortality is very high, and we need to clear the worm by administering ivermectin until the stool and sputum gets negative for 2 weeks. And also the background history, there was a history of recurrent episode of loose stools, followed by which he was treated as inflammatory bowel disease and was administered medicines for the same, which could have a similar presentation to that of a strongyloids intestinal manifestation, as in there is a skin pattern of the inflammation, the distal attenuation of the disease, eosinophil rich infiltrates, which can mimic the ulcerative colitis. And there is a case report that shows that a misdiagnosis, instead of strongyloids, considering it as ulcerative colitis, is 52% in this case study, and also resultant mortality rate due to the misdiagnosis at 39.1%. And coming back to a patient, he's currently in ICU. With regard to the sepsis, his shock is resolving. The CSF, the pus cells are also being reduced, and current evaluation planning is for the any CSF rhinorrhea workup. And learning points is that always consider a rare cause, like a organism in the CRO E. coli in CSF should alert to look for any other causes like strongyloids hyperinfection also. And also this chronic strongyloids infection can mimic the inflammatory bowel disease also. Thank you.
Thank you. Yeah, just one question. Do you think it was a primary strongyloids causing colitis and then now this, or do you think it's the patient had an IBD and because of steroid intake and other immunosuppression had a strongyloids hyperinfestation and then it caused this meningitis?
The first complaint is it could be the initial strongyloids that he was having before.
So I think the patient has been having strongyloids as the primary pathology going on for a long time.
Yes.
You don't think it was IBD immunosuppression which
Because
caused
on
strongyloids?
immunosuppression also he wasn't improving. He admitted twice also after initiation of the drugs.
Any questions from the floor? Okay. Yes, thank you. Who wants to add a comment? We'll move on to the next presentation by Dr. Rebecha from Medicine 2 on